Ladies and gentlemen, welcome to your next session on diabetic emergencies. We are going to deal with hypoglycemia in the session today. Hypoglycemia is defined as a laboratory blood glucose of less than 4 millimoles per liter associated with symptoms. This definition can vary depending on whether you are with the DVLA or using it for research purposes. However, everybody is quite united in that severe hypoglycemia is any degree of hypoglycemia where the affected person cannot take corrective measures and require third-party assistance. This is not a friend offering a drink, but the fact that the person who is affected is physically not able to find glucose for themselves and correct hypoglycemia. Acute hypoglycemia is most commonly due to excess insulin, particularly in those with type 1 diabetes, but also can occur with type 2. It can also occur in the setting of excessive sulfonylurea use, alcohol excess, liver disease, and sepsis. The more unusual features are more unusual causes are insulinoma, pituitary or adrenal failure, and salicylate poisoning. Acute hypoglycemia, one has to recognize that blood glucose monitoring with a blood glucose finger prick test is inaccurate, and as far as possible we must do a formal laboratory blood glucose. It must be treated as an emergency as it can deteriorate and lead to seizures and a significantly worse clinical state. It can also trigger angina and cerebrovascular accident. Always use oral glucose when possible, but intravenous glucose is preferable when consciousness is impaired. Recognizing hypoglycemia is the big challenge. It is a great mimic. It can mimic cerebrovascular accident with focal neurology, myocardial infarction with chest pain, and acute delirium. If you think about it, you will test for it. If you don't think about it, the treatment can be significantly delayed. On the other hand, in a person who's had type 1 or type 2 diabetes for a long duration and has experienced multiple hypoglycemic episodes, they may not be fully aware of hypoglycemia, and this is termed hypoglycemia unawareness, and the patient may not be able to recognize hypoglycemia due to the lack of adrenergic warning. The symptoms can be adrenergic and occurs when the blood glucose is less than 4. It's usually associated with palpitations, anxiety, shaking, sweating, hunger, and a sense of impending doom. If the blood glucose falls further, there can be neuroglycopenic symptoms, which are confusion, ataxia, slurring of speech, which can further lead on to coma and seizures. Now, this is a cartoon which shows you the response to hypoglycemia. The green line is the fall of blood glucose, and as you can see, as the blood glucose falls below 4, stress hormones start to kick in, particularly adrenergic hormone, so adrenaline and noradrenaline flood into the system. Neuroglycopenic symptoms occur further later, and confusion or talking incoherently may be the first signs. However, it must be recognized that impaired response and judgment, particularly when driving, can occur even before the onset of neuroglycopenia. So the response time to an acute driving emergency may be actually significantly delayed and comparable to a person under the influence of alcohol. This is the reason why the DVLA often tend to look at hypoglycemia-induced accidents very seriously. This is a busy slide, and I shall in future slides explain this in more detail. This is the management algorithm for hypoglycemia. You may wish to pause the slide at the present moment. Pause the slide on in order to study this further. So hypoglycemia can lead to a variety of different symptoms, and if IV access is available, you go down this route. If there's no immediate IV access, you can go down that route. If the patient is conscious, alert and coherent, you can give glucose by mouth, and there are a variety of different remedies mentioned here. I suppose from this slide the important factors are even after you've corrected it, don't leave the patient. Make sure that you check blood glucose every 15 minutes. There's the rule of 15. Give 15 grams of glucose every 15 minutes. And you can double the dose if the blood glucose is less than 2.5. The quicker you correct hypoglycemia, you can abort the severity of the rebound and subsequent hyperglycemia. The other factor to take away from the slide is never discontinue insulin in a patient with type 1 diabetes and review the dose. Stop insulin for a maximum of 20 minutes and make sure that the focus of correcting hypoglycemia is giving glucose rather than omitting insulin for prolonged periods of time. So if I look at the previous slide and then try and distill that further, the decision-making points are as follows. So when you suspect hypoglycemia, is the patient conscious or not? Is the patient safe to swallow or not? If they are conscious and able to swallow, then you go down this route by giving 15 grams of glucose and then making sure that the blood glucose is more than 4 and giving something more substantial later. If, on the other hand, the patient is not conscious or is unsafe to swallow, you check whether they have IV access. If there is no IV access, you give them glucagon, bearing in mind that glucagon may not be effective in advanced liver disease as well as sulfonylurea overdose. You may need to still find an IV line and give them IV glucose. Acute hypoglycemia, IV infusion may be required, and remember that the IV infusion may need to be given for much longer than the duration of hypoglycemia. Make sure that you, if it is sulfonylurea that has caused it, check whether there's been a mismatch between food intake and tablets, and then make sure that you try and avoid hypoglycemia from occurring at the same time the following day. Driving in hypoglycemia, the DVLA is very keen that all drivers have a good understanding of hypoglycemia and diabetes. This includes control of the car during driving lessons, learner drivers, and this point is often not emphasized, particularly in our younger type 1 diabetes patients. Hypoglycemia is very important for those on insulin, but more important in people who are not aware of all episodes of hypoglycemia. This is when drivers apply for a driving license, they have to give a certification that they are aware of all episodes of hypoglycemia and that they test on a regular basis. So if I start from the last point here, DVLA rules regarding driving: always test before you drive and 2 hours into the drive. If you're on insulin, if you're on sulfonylureas, test at times relevant to driving. Your blood glucose needs to be more than 5 millimoles per liter to drive. If you have 2 major hypoglycemic episodes as defined by requiring third-party assistance, the DVLA may revoke your license. Impaired hypoglycemia is a relative contraindication, and the patient will need to work hard with the diabetes team to ensure that they regain some of the hypoglycemia symptoms before they are allowed to drive. If a patient has a hypoglycemic episode while driving, they will need to remember that they are driving under the influence of a drug, and the what is recommended by the DVLA is that the patient, when they recognize a hypoglycemic episode, need to switch off the engine, take the key out of the ignition, move from the driver's seat to the passenger seat, and these are the 3 steps that have to be done to ensure that they are no longer in control of the vehicle. They can only resume driving 45 minutes after their blood glucose comes above 5 millimoles per liter. It is certainly not acceptable to have a Mars bar and carry on, as some people may think it is okay to do. One particular factor that you need to take into account is insulin overdose. Now we have short-acting insulin and long-acting insulin. However, in overdose, many of these profiles that are advertised by the drug companies no longer apply. Short-acting insulins actually become long-acting insulins if they are given in overdose, and you need to monitor them for 6 to 12 hours. Most flat profile insulins lose that flat profile and may have a peak, and they might get hypoglycemia for up to 24 hours after their insulin overdose. Ensure that this period is covered with IV dextrose. That covers hypoglycemia. If you have any queries, please do not hesitate to send me an email, and I shall endeavor to respond as soon as possible. Thank you for your attention.